Thank you so much for joining us.
It's a real pleasure. Thanks for having me.
You bet. And so what we want to talk a little bit about today is what is hyper and hypothyroidism, and what does that mean as far as your test numbers. But also, what is Graves' disease and Hashimoto's disease, and are really they the same as hyperthyroid and hypothyroid? Because there's a lot of confusion, and then the answer is it's kind of a complicated answer.
Right. So, hyperthyroidism is when the thyroid gland is producing too much thyroid hormone. Hypothyroidism is when it's producing too little. Now, there's two kinds of autoimmune disorders that can affect this. Let's start with Hashimoto's, which is a fairly common disease or circumstance. Hashimoto's happens because there's an antibody to a certain specific protein on the thyroid gland called the thyroid peroxidase, and the antibody is directed towards that. When the antibody attaches to those proteins inside the thyroid gland, the immune system attacks thinking it's something foreign, right? And causes inflammation of the thyroid gland. Acutely, in the first attack or at the beginning of every attack, that causes a lot of hormone to be released from the thyroid gland. So the Hashimoto's patients, right at the beginning of every attack, may have a period of having too much thyroid hormone, a hyperthyroid state. But that's very short term, and it's followed by a period of having too low because the gland is getting attacked and it's not producing thyroid hormones anymore. So patients have an high T4, T3 state, and then they go on to having low T4 and T3 in the bloodstream and with a higher TSH. And these patients, when you follow them in the long term, they have periods of attacks and periods where things calm down. And with each attack, the thyroid starts working a little bit less. And when you follow these patients in the long term, you'll find that they go through attacks, they get better, and at some point they'll just stay at a low state where they just can't produce enough thyroid hormone. That gland has been affected too much. It's had too many attacks.
And that's what I think is so frustrating for so many patients is that it's hyper then hypo, and they feel that they're bouncing around so frequently.
Yes.
And which is true because your hormones are constantly changing, and it directly affects how you feel and function.
Absolutely. The majority of patients who have Hashimoto's disease don't actually know it, right? Because it happens in small phases, so the effect is not really deeply felt. It's subtle, and it can progress in time and become more obvious. But the majority have subtle disease and don't know it. Right? We may find out when we're doing thyroid surgery for a nodule, we may look at the thyroid microscope and they'll say, oh yeah, you also have a background of thyroiditis or Hashimoto's. Okay? But some of the patients will have these attacks, and those patients generally can recognize when an attack is coming on and prevent it by taking steroids and decreasing the effect of the attack, the immune attack, to modulate. And the ones in the long term, when they have a hypothyroid state, obviously have to take thyroid hormone replacements in that case. Now, the patients with Graves' disease have an entirely different manifestation of an autoimmunity. And they have, because they have a different antibody. Their antibody is towards the receptor in the thyroid gland that the TSH attaches to. So TSH attaches to this receptor, stimulates the thyroid gland to produce extra thyroid hormone. When the antibody does the same thing, when the antibody goes and attaches to that receptor, it falsely stimulates the gland to produce extra thyroid hormone. So you'll have an elevation of your free T3 and free T4, and the brain will try to modulate by decreasing the TSH that it has, but it has no effect because the antibodies have hijacked the system in a sense. So those patients will have very low TSHs and higher free T3 and T4. And those are the hallmarks of the disease. And the final diagnosis can be made by looking for the TSH receptor antibody. And once you recognize, when you do a blood test for that and you see that confirms the diagnosis.
And there's at least two types of receptor antibody. One is where you just look at the receptor antibody and you measure the antibodies that are available. And the other is where you look at what the antibody does to stimulate cells, and that's called the thyroid stimulating immunoglobulin, or the way of actually measuring what that antibody does. Because not to get too complicated, sometimes instead of the antibody causing a positive signal, it actually blocks the receptor. But we won't make it too complicated, for this particular show. But that is something that you should at least be aware of, that there are at least two types of antibodies to be measured. One, the trap, and one the TSI. I almost uniformly order the TSI because I'm looking for a diagnosis. I'm looking to, and it's the most sensitive antibody. The TRAb can be elevated, but it doesn't necessarily give me a diagnosis for most of my patients.
And once you have the diagnosis and you know what disease you're dealing with, then you can address it appropriately, And if you have a hypo or hyper state without actually having Graves' disease, right? So you can have a hyperthyroid state from a nodule that produces extra hormone, right? And what you have to do, you can control it with medications, or you can control it by removing that nodule or that portion of the thyroid gland. So those are easier, less complicated surgeries than what you may need to do.
A lot of patients do have these nodules that are recognized incidentally because they get Graves' disease, and all of a sudden they have a thyroid workup and they have a nodule too. What dictates how that nodule should be dealt with?
Well, first, when you have a hyperthyroid state, you want to know if the whole gland is producing extra hormone or if it's the nodule itself producing the extra hormone. Because if it's the toxic nodule, we call it, the one nodule that's producing the extra hormone, then you can address it by just removing that nodule and keeping the rest of the normal gland, in which case you'll have a normal life and you may not need to ever take any thyroid medication. That's the better condition to have of all the things that can happen. It's more simpler and the long-term consequences are less. Right? But great majority of times it is the entire gland that's malfunctioning, in which case you have to actually address the whole gland either with medications, radioactive iodine, or thyroid surgery. And the decision in which direction to go can be a complicated one, which requires having multiple experts, including endocrinologists, orbit surgeons, and the actual surgeon communicating with each other to figure out what's the best path for each individual patient.
And it is a very individualized approach. Most data does point that thyroidectomy probably reduces the chance of worsening eye disease in Graves' disease, and it does so pretty strongly, where radioactive iodine probably lends itself to aggravating the eye disease. And so at least on the far ends of the spectrum in patients with moderate or more severe eye disease, I tend to recommend thyroidectomy, given that other parameters and that they're an appropriate candidate for that type of surgery, because it does restore their thyroid equilibrium very quickly, and it also reduces, or at least does not aggravate, the eye disease.
Right. So radioactivity, of course, has its own inherent issues, because the radioactivity is non-specific. When you do radioactive iodine, it does affect the thyroid, but it can also affect salivary glands and other tissues in the lung. Fertility issues can develop. So you have to pick the treatment that's appropriate for each patient.
It's worth an in-depth discussion, and I often refer my patients to an expert like Dr. Larian for thyroid surgery evaluations, but also for an endocrinologist for radioactive iodine or medical evaluation, so that each individual can make up their mind. And we haven't really gotten into the natural substances or the additives, but that's also a discussion that can be had with patients. But thank you so much.
Real pleasure. Thank you so much.